sick and tired of the high costs and inefficiency plaguing our U.S. healthcare system? Do you feel like you're navigating a maze when dealing with insurance companies, only to end up paying a fortune for basic medical services? Then this Broken Healthcare podcast is for you. So get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Kober. I am your host, and I am delighted to have with us in the studio today Rob Archibald. Rob, welcome to the big show.
Thank you, Ray. So glad to be here.
Right on. So I met Rob at the Health Rosetta Fest conference in DC this past September, and it's an event where movers and shakers from across a number of different industries. We have medical professionals, we have broker advisors, we have all sorts of folks in the healthcare space, vendors, consultants, come together like a melting pot. And was fascinated to meet Rob. He was a panelist, and I don't know, did you have more than one venues that you were speaking at? I know that you were on at least one panel that I caught. But you're doing some really innovative things in healthcare, and I'd love for you to share with the audience a little bit about your mission. Is this something you're passionate about? Is this a get-rich-quick scheme for you? What are you doing here, Rob?
Yeah, you asked the wrong question to start off the gate. Am I passionate about something? Like, nobody asks that question unless they want an earful, especially if you're not in healthcare. Like, my wife will get me going and I'll just talk about healthcare for a really long time. And she'll be like, that is the most boring thing on earth. How can you actually be interested in that? It's terrible.
Yeah.
Yeah. So prior to my world in healthcare, I was actually a tech guy at Intel. So that's how I started my career. I graduated from school and thought I was just going to do tech my whole life. Of course, I am still doing tech.
And wait, so you left Intel and everything went downhill for Intel after you left?
It absolutely did. Absolutely did. Yeah. I left there so I was there for 16 years. I left there in 2015.
Okay.
And so I got to watch, I started in 99. I got to see it go up to its peak, and then it went downhill ever since then. So yeah, I got to see everybody around me becoming millionaires, but I didn't actually become a millionaire myself. Because when I joined, every 6 months we did this stock split thing. And I tell you, everybody around me, I was looking around, and I was like, oh, these people must be millionaires because their stock splits and doubles every 6 months. And it looked like everybody around me was millionaires. And there was people telling these stories about their $1 million station wagons because they would take out a little bit of money to buy their station wagon, and then it would go up to quadruple since they bought it or whatever. And they're like, wow, that was my $1 million station wagon. But that was never me. So I didn't really get to enjoy that. I got to enjoy the very slow downward trend of Intel during my entire time that I was there. Huh. But I loved my time at Intel anyway. They're a great company that were doing a lot of amazing things when I was there. And I guess the thing that I also loved about it was just the discipline of technology of, you're working with one of the largest enterprise companies in the world. You have to be able to develop software in a way that is mission critical, that's never going to go down. I used to have one of my coworkers would say, if the fab goes down for an hour, which I worked in supporting one of Intel's fabrication plants, they talked about how it was $1 million an hour to take the fab down. So in my young heart that was making $40-something thousand a year, I was like,
not on my watch.
Yeah, exactly. Not on my watch. So yeah, it made me really nervous, but I learned a lot about how to build really safe, secure software because that was the world
I'll bet. And we'll talk more about what you're doing today. I don't want to get too off the beaten path, but on your website, I did notice a graphic that said 99 point something uptime, right? So that's still something that you carry with you to this day. It's almost like you wear that as a badge of honor. Like, hey, if it's going to be a company that I'm involved with, you're going to know that your uptime is important to us. And it really is. The last thing you're going to have to worry about is downtime.
Absolutely. Yeah. And one of the things I'm passionate about, I believe, we talked about this a little bit last time, which is I believe that administrative costs, the waste in healthcare is anything that's not paying the salary of a doctor. Anything else, like in an ideal world, we would have, and I know this may not sound great to a broker who's sitting in the middle trying to make a living. So we got to have something in there. But in an ideal world, we have as little going on in between the doctor getting paid and the person that's paying for that care. In the olden days, we used to have just cash pay for everything. Now we have an employer that sits in the middle, but it'd be ideal if we can cut out all that administrative costs. And so when you talk about uptime, that's what we built our company around, is this idea of, I want to build APIs that make it so that when you slide a credit card in, when you're done at the end of a visit, that we can take out all of the payments through all of the contractual relationships with providers at the time of service in milliseconds. So that's why things like uptime matters, because if you're trying to build that kind of ecosystem, you have to start from the beginning with the end in mind. My last company that was a miserable failure was called Infirst. And we said, we begin with the end in mind. Well, this is my mantra, begin with the end in mind. So we built it with the idea of, we're going to make it so that healthcare payments are completely effortless, like just the swipe of a credit card. And that's what we're building towards.
Yeah, that's cool. And I do think that brokers should only be involved in the middle of a transaction if they're adding value. If they're not adding value, then why even have a broker? You don't need a broker. It's the God's honest truth. If you're running an organization and you're offering a medical plan, health insurance, benefits to your employees, you should only have a broker involved if the broker adds value, helps you dissect the market, truly is almost like, I would call it a paid gun, a hired gun to sit on your side of the table to ensure that you understand all of your options and they are working in your interests in total transparency, which is the true spirit, I think, of Health Rosetta. It's empowering employers so that they know exactly where all the bodies are buried so that they can make informed decisions, right? That's the whole idea. And it's crazy to think that in healthcare, a profession that in the name is health, and then care is the other piece of that compound word, it's so rife with opacity and corruption and greed, and it really is in a pretty sad state. And I think those are some of the things that you're passionate about, is putting an end to that, delivering transparency, cutting out the waste and bloat. Do I have that right?
Yeah, absolutely. Yeah. So that was one of the things we talked about at Rosetta Fest, was this new metal open data platform. And when I think of an open data platform, what that means is we're going to capture all of the information that's coming in about a transaction and identify what's going on with that. As I mentioned, our ideal goal is we make it so that those payments and everything that we need to do is all happens at the time of service, so that there isn't all of this delay in payment and things like that. But until then, we've got a lot of additional work that we need to do. So, let me give you an example of waste, like you talked about. Marilyn Bartlett talked about this at Rosetta Fest. And it's not just waste, it's criminal. I mean, literally criminal.
And who's Marilyn Bartlett for our audience?
Yeah, great. Marilyn Bartlett, she's one of the legends in healthcare. She used to be the administrator for the Montana Health Plan, Montana State Employee Health Plan. She turned it from a massive deficit into a massive surplus. And then, of course, later when she left, Blue Cross came along and put it back into deficit. So congratulations. But anyway, in her world, she made amazing things happen. And she talked in Rosetta Fest about how there was an example of a 2024 lawsuit, so this year, just recent, in which company was really upset with Cigna, their network that was, adjudicating claims for them, because they felt like they were getting ripped off. And in discovery, they found out how bad they were getting ripped off. And when I tell you ripped off, I don't mean ripped off like I'm just being mean to you, ripped off as in criminal. And by that, I mean, they took a claim where it came in at somewhere around $1 million. They actually jacked up the price to $11 million. So again, right off the bat, we're talking about robbery. You're saying, I'm going to turn it into $11 million claim. Now, why would somebody do that? They do that because what they want to be able to do is they want to be able to take a percentage of savings. And they look at that $1 million claim and they say, well, maybe there's not that much opportunity for a percentage of savings for me. So they'll jack it up, and then they'll take a really steep discount off of that $11 million claim. And then they get to claim that they have saved all this money. So in this particular instance that she brought up in Rosetta Fest, they had multi-plan. They got paid about $900,000 on that $1 million claim. The provider got paid about $900,000 for that $1 million claim. And Cigna got paid $2.5 million on that claim. So you basically took a claim that was just short of $1 million and you turned it into a $4 million claim by spread pricing. And this is illegal. So this isn't just like my contract terms are unfair. This is what I would call robbery. If I went into your home and stole $4 million from your account, you would call me a robber and you would put me in jail. And that's what I think ought to be happening in cases like this, where not just we're solving the problem of unfair pricing, we're actually putting people behind bars for unlawful business practices.
Oh, 100%. But unpack that for me. So how do the mechanics work? Is it $1 million charge to begin with? And are we specifically talking about a drug that was jacked up? Or are we talking about services that were rendered in a hospital setting and the charge master was 10 million and ultimately the paid claim was 4 or 5 million and Cigna got their piece and the network got their piece?
So it would seem that would be the case, that it was actually $11 million claim, but no, it was a billed charge of $1 million.
A bill charge of $1 million.
And then they jacked up the billed charge to 11 million so that they could get a percent of savings, even though they didn't save anything.
That is egregious.
So that's why I call it robbery.
Thievery.
It's not actually just unfair business practices. It's robbery.
And this is hidden.
That's what's happening in our healthcare.
This is buried in the minutia of the complexity of the billing that is the health plan, right? This is
Absolutely.
not, the employer didn't get a statement that said, oh, you had a charge for $1 million. Cigna jacked it up to 11, claimed savings, pocketed 2.5. That's not what happened. What happened is this was picked up on an audit. And I guess Marilyn was astute enough to, how did they uncover this? You tell me.
I don't know all the details. What I'm told is that it was a part of a lawsuit, and then she and some other people that have been looking into this lawsuit uncovered this.
There was discovery, and there it is. Wow.
Found out through discovery. And so it's not the first time I've heard this happen either, where a network will take a plan or a billed charge, and they'll actually jack up the billed charge just so that they can get an additional percent of savings. And then they'll end up paying the same amount as what the provider actually asked for. But to me, if you change the billed charge, I don't care what your contract says, that is robbery.
Yeah.
And if you're getting paid more than what the provider was, who actually saved lives, you are, in Rosetta Fest, I called this pirates. So if you're trying to save money to the plan and you're making more than the provider gets paid, you're a pirate.
Right. A lot of hands in the till and a lot of middlemen that are also getting paid, and nobody knows what the cost of anything is. That's my thing. Is people will shop all day long on Amazon, or they'll Google a lawnmower or a barbecue grill, or even do comparison shopping for an automobile to find out what's the best price. No one gives a shit in healthcare. It's just like, oh, I have a magic plastic card, and when I bring that card to the hospital or my provider, my doctor, I put the card down, I pay my copay, which is an insignificant amount, generally speaking, and I'm on my way. And right. I'm not blaming the average working citizen. It really starts at the top down. And the truth of the matter is, dare I say, most HR directors, CHROs people who are in the business of procuring healthcare on behalf of their organizations, most have an idea, I think, that there's corruption. But to the extent that you just shared, I don't think anybody has a clue. This stuff happens every day. And that's an extreme example, particularly when you think about the dollar amount. But there are bill charges all day long in hospital systems where the charges are basically, they're complete fiction. I've heard stories of a hospital in Texas that bills for a pregnancy test if you're admitted, whether you're a male or a female. And it's just part of the process. And so these bills that are pages and pages and pages long, it's all buried in code and no one could understand what the hell's going on. But we have to pay attention, folks. If you look at this stuff and you look at the billing detail and you see an obvious mistake, let's call it a quote unquote, air quotes for those of you that are listening, mistake, we need to shine a light on that. But it all starts, I think, with just being better consumers. And by that, we all have credit cards. No one rolls around with wads of cash in their pocket. And many of us are guilty, myself included, of blindly paying a credit card bill. But every once in a while, I'll get a charge and I'll be like, wait a second, what is up with that? Right. And you go down line by line and it's like, holy crap, I never bought that. I never ordered that. So you want eyes on your claims. And that's something that we all could do a better job with. And I think that's where you come in, if I'm not mistaken. So just give us the 30,000 foot view, because your services are not necessarily going to be member facing, right? The person that goes in for an MRI or a CAT scan or a routine physical or even a hospitalization, a knee replacement, or this or that, they're not necessarily going to be in contact with your service, or are they?
Yeah, I think eventually that'll be something that we'll enable. But I think for now, the primary focus is on plan administrators, people that are trying to make the differences. You mentioned brokers at the beginning, consultants, people that are actually looking at what's going on in a plan and trying to say, what's the problems here? So let me just give you the brief rundown, like you said, which is every single time a bill comes to a plan for payment, it's like any other bill in that business. They receive a bill. In this case, it's in the form of a claim, and there's line item details that say this is what should be paid. So first and foremost is with this metal data platform is we load every one of those original claims as they came in. Why is that important? Because if I got a claim, take us back to that Cigna example, if I had that claim in my claim system and it told me that the billed charge was $960,000, and then Cigna comes back and says, oh no, it's $11 million, I'd be like, screw you, it is not. It is $960,000 and I will not pay a penny more. So that's answer number one, is we get all the original claims data from the provider, undoctored, unchanged, whatever. So this first off solves probably 80 to 90% of the spread pricing problem, because the spread pricing problem in claims comes because people just trust that healthcare is expensive. And so when they see a claim for $11 million, they don't, because they've happened before and they've happened a lot. And so they're like, well, whatever, this was a bad situation, so it's just what we got to deal with. So number one, you get all the data, you know exactly what the original price was. Number two, we then get all of the post-adjudicated claims data. So now the TPA then goes in and says, this is what the priced amount is, and this is what it was paid at.
Is it hard, Rob, to get the data? Is that what your APIs do? Is it difficult to get the actual numbers? Is that just a feed from the providers, or how does it work?
I wish I could say that for every network out there that they will just freely give you all this information. But the reality is some of these networks are screwing you over on the back end. And so they're not going to give you this information. But what I can tell you is that we have a lot of very transparent TPAs that are very willing to give you all this data. And so what we do is we load all that pre-data, we load all the post-adjudication data, we reconcile it together. And now at that point, you can say, hey, this is what it came in at. These are all the adjustments that got made. This is what I paid. voila, you have all the information about where your money's going. Now, we don't yet have full GAAP accounting. If you're not familiar with GAAP, that's generally accepted accounting principles. That's one of the things we're moving towards, is we want to make it so that healthcare, you can do GAAP accounting with healthcare. Gee, what a thought. You wouldn't think that healthcare would be something that we would require GAAP accounting on, but we do on every other expense that goes through a business. And why don't we do that with healthcare? We don't, because networks and carriers will stand behind this idea that there's this HIPAA problem. And there is some truth to this. Let's be clear. There is some truth to the fact that you can't just give all of the information, because if you find out, if you don't do it in an unredacted way for a small business, for example, you might know that, hey, Sally was out last week and it shows here that there was $1 million claim at this particular place and she's out for an entire week. Oh, that was probably Sally. I should fire Sally because Sally has a big problem. And now I can save money on my healthcare spend by firing Sally. That's what the networks are using as their example. And it's a legitimate example.
It's a legitimate example. However, an employer can be privy to that information. The problem is in the firing piece. If the employer then turns around and fires Sally, that's where there's an issue. By and large, health insurance carriers and the like use HIPAA as a shield to say, we can't give you this information.
Yeah, exactly.
But the real answer is they're not giving you the information because they give a rat's ass about your employees or your members.
Right.
They don't want you to see what they don't want you to see.
So there's training, there's ways that we do reporting. There's a lot of things that we need to do to adhere to HIPAA standards. So let's not be flippant and say that we're just giving people all the data and we're not caring about HIPAA, because it's really important that we do that.
Right.
But at the same time, it's the right of an employer to know what's going on in their plans. That's the vision, is to be able to do full-on GAAP accounting with this data as it comes in, just like you would any other expense in your business. And you can see, oh, I'm spending this much money on diabetes point solutions. I'm spending this much money on MSK point solutions. I'm spending this much at claims at provider X, Y, and Z. And then I can look at that as a holistic exercise and say, you know what? Just like 32BJ did in their large list of members, they identified a provider that they were spending more money on than any other provider in their network. And they said, we want to take them out of our network. And that is a legitimate and reasonable use of claims data.
I'm sorry, what is 32?
Yeah, great question. So 32BJ is the SEIU chapter of the Service Workers Union in New York, New Jersey, and several other large places. And they've done fantastic work at analyzing their claims data, because they're big enough and they've got a transparent enough TPA that they can get that kind of information.
Got it. And so having that insight made them better consumers of healthcare on behalf of their membership.
Absolutely. Yeah. And it turned out that it was so valuable to them to have that data that they gave all their service workers across their entire business. So 200,000 people, they gave bonuses to 200,000 people. This was like the first time that they'd ever done this. And it was coming because of savings in the health plan. So you want to think about this. Like, we have to recognize that it's projected that somewhere around 2030, that the average cost of healthcare will equal the average wages of an employee in this country. Now, if you take service workers that are usually on a little bit lower end of that wage spectrum, and you say they're probably going to get there sooner. Last reports that I looked at, their healthcare spend was about 46%, if I recall correctly, of the overall compensation package for that person. So they're really close to, if you can then cut the cost of healthcare by 50%, which that would then get the United States comparable to all of the other developed nations in the world, all of those service workers would get a 50% wage increase. This is real stuff.
Yeah.
Oftentimes employers and employees think, oh, well, it doesn't matter that I went to the most expensive provider in the city. I got amazing care. No, it does matter. It affects your bottom line and your paycheck.
Oh, no doubt. And going to the most expensive provider doesn't ensure that you're going to get the best care.
Exactly.
That's a conversation for another day.
Exactly.
But the mind blower is Just getting back to a small appliance example or a barbecue grill, you don't walk into Home Depot and you walk in, Rob, and you see the price of that Weber grill and it's $699. And then I walk in 10 minutes later and I see the price of that grill and it's $999. And then Bobby walks in and the price of that grill is $1,600. It doesn't work that way in the real world. But you bet your ass it does in healthcare because the charge master has got dozens, if not hundreds of prices for every CPT code that's out there. And without knowing or having a compass or a way to measure what the baseline is, how do you know you're not being fleeced?
Yeah, absolutely. And so that's another aspect of what Metal brings to the table is that when we load all of this data, we also are augmenting the data in it with additional information to give you the sense of if I'm getting screwed or not. So if, for example, I can take, say, Medicare, some people will say, I don't like Medicare as a benchmark, but it's an amazing benchmark because I can compare from provider A to provider B, who may have different cost levels, who may have different wages and different things like that. It could be across states, it could be whatever. And I can compare across those providers and say, is this a fair rate? Now, I'd love to be able to just say in every case, I should be able to just compare dollars to dollars. And that's still an important way of comparison, but you can't always use that. And so Medicare gives us that sort of baseline that allows us to then say, hey, we're paying 1.3 times Medicare here. This place we're paying 2.3 times Medicare. And the average employee healthcare plan around this country is paying about 2.2 times Medicare. That's 2.5 times the amount that the federal government pays for the same thing. And there's been a lot of studies that have been done that have defined that Medicare is built in such a way that it covers the costs, and for most providers even gives them a small profit if you're running Medicare. And there's a lot of businesses out there, a lot of healthcare companies that are built on just Medicare patients, and they make a handsome profit. So what that tells me is if you're paying somebody 2.2 times what their cost is to deliver goods and services to you, if you had a procurement department in your company, you would be having a serious conversation with them. If they're your number one top line revenue or top line expense, you'd be having a serious conversation with that vendor saying, hey, you're charging me too much. You're making way too much money off of this, especially when we think about healthcare, the way that healthcare was designed for this country and the way that the providers and clinicians in this country want to provide healthcare. Providers and clinicians want to provide healthcare to save lives and make people's lives better. They want to heal people. They want to make a difference. And then administrators have come in and said, oh, we have this amazing captive audience of providers who are willing to get screwed over day in and day out, work way more hours than they ought to have to work, see way more patients than they should have to see. We're inflicting moral injury on these providers to serve profit needs. And so these amazing business people have gone in and used this captive audience of providers who are willing to do this because they love people and they want to make a difference for their profit motive. And that, to me, is another reason why all of this is wrong. Like, we need to take healthcare back to its roots, where healthcare is, we're helping people, we're making people healthy, we're figuring out how to identify the best care and the lowest cost care. Instead of today, we have hospitals and health systems whose whole goal is to get somebody into an inpatient procedure. Why inpatient? Because that's where they make the most money. I want to keep them overnight for multiple days. I had a good friend that had a heart issue. He thinks it was a heart issue anyway. He fainted, he fell over and pretty much passed out, but wasn't completely out. His family was super nervous. The guy is super healthy. He's a contractor and very healthy. And they took him to the hospital because they were, of course, worried about him. They get to the hospital. They do a bunch of tests. They didn't find anything wrong. They kept him for 3 days, did an echocardiogram and whole bunches of other tests. And then they tried to offer him a monitor to send home with him. And he has this conversation with the hospital administrator before he checks out. And the hospital administrator says, hey, we'd love to send you home with this monitor and all this other stuff. And you do realize that I don't have insurance and that's going to cost a lot of money and I don't have that money, right? And the hospital administrator says, oh, wow, it's a good thing that we didn't know that, because you got way more care than you would have otherwise gotten had we have known.
Oh,
So yeah, hospitals see somebody as an insurance card. They don't see you as a patient.
right.
They see you as an insurance card and a way to bill. So why did that administrator come in at the end of the day to say, I want to send you home with a monitor that could cost hundreds of thousands of dollars?
Right.
Not because they wanted to help the care of this patient.
Not a word about that.
He had talked to all of his doctors that did the tests.
Right.
And they were saying, I don't see a problem. I don't see a problem. I don't see a problem. And then at the end of the day, the administrator comes in and says, can we send you home with this monitor?
Yeah.
And he's like, it's not medically necessary, and you're just trying to fleece me. And that's unfortunately what's happened. We have doctors and clinicians that want to help people. They'll tell the truth. They'll tell you don't need the surgery. You don't need these treatments. But administrators are out there pushing their agenda, which is we need to get more services on this person.
This episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. There's so much wrong with the system right now, and it is truly rife with corruption at just about every level. And look, this show is never a slam against the medical community, against the good, hardworking doctors, nurses, surgeons, and many of the fine institutions that employ them. It's really a call to action, though, for folks to wake up and just understand that there is a price tag that goes along with medical care and the services that you receive, and you need to start paying attention to it. It can't be buried behind your insurance ID card. In the case of your friend, thank God they didn't send them home with that stuff. I'm almost afraid to ask if the treatment that he did get put him into bankruptcy court, but because, as Rob, the number one cause for bankruptcy in the United States is medical debt. And it's for folks like that who are underinsured or don't have insurance that sign a financial waiver when they're rolled into the emergency room. And the next thing you know, they're admitted as an inpatient, and hundreds of thousands of dollars later, they're discharged with no problems. Thank God I'm okay, except for the fact that they have to now sell their home and declare bankruptcy. So it really is a huge problem. So this issue with not this issue, but the service that you provide, can you quantify it? Is there a before and after where, okay, just also clarify for me, are you saying metal like gold, silver, or metal like bronze medalist? I guess it's 6 of one, half dozen of the other. And where did the name come from?
Yeah, great question. So it's METL is how it's spelled. And it actually is related to the fact that it does a lot of extract, transform, and load. And I'm a nerd. And because I'm a nerd, we were like, hey, it should be like an ETL tool, but that's lame. So let's make it the My Price Health ETL tool or the medical ETL tool. So then it became metal. And so then it just stuck. So like it's way bigger than that now. So we not only can do actually transforming data to get data into the system and get data out, but we also do a lot of work with, we have UIs. We can, you can actually view all your claims. We have some reporting capability. We also have some UIs for making it easy to get data in and out. As a consultant, for example, you often are stuck with a situation where you have a client that you want to help them. And you happen to be in a situation where you get claims data from them. You have historical claims. So this is your ideal scenario. A typical consultant is looking at that data and they're like, I don't know how to make sense of this. I don't know how to make heads or tails of this. So I'll just give you a quick scenario. You would take that data, you would go to Metal and you would say, hey, let's load this data in. You use this little wizard. The wizard is capability we're currently finishing up. And you use the little wizard. The data loads into the database. We then apply all those benchmarks. So now you can see where where the pricing fits in accordance with like others within the industry. So you can see if you're getting overcharged. And then you can then say, hey, I want to do maybe some cohort analysis. Maybe I know based on some data or just a gut feeling that maybe we've got a lot of diabetes candidates in our sample of employees. So let's do some cohort analysis on that and say, hey, what does it look like? Which of these people look like they would be candidates for diabetes special care? And then we can identify, hey, let's build a solution off of that. And oh, maybe this is a group of people that needs special MSK care. And so that's what metal is designed for today. That's the primary use case for today, is figuring out how much you can save compared to a traditional health plan, but also once that plan goes live, being able to manage it over time, because now because you're getting all of that live claims data as it comes in, and you're seeing how it's paid afterwards, you can see exactly what's going on, and you can see where your outliers are and where your problems are, and you can fix them. So it helps with, like, the way I like to think of it is it's meant to help with the entire life cycle. Everything from the place at the beginning where you're doing savings analysis and you're trying to figure out what the problems are with your plan, all the way through to managing the plan day to day. We even have some third-party administrators that are looking at using metal as their adjudication platform. So they're going to build on top of metal to build an adjudication platform on top of it. So that's the power of metal. Is, the data of healthcare is not really that broad. Like, a lot of people think that healthcare data is just tons and tons of data files and information. And no, it's actually, there's a handful of standards that have been defined by CMS and by the government. Those are required for everybody to use them. We've implemented all those standards, which means all the data that's available in all those things are available in the database. And then you can make decisions off of all that stuff.
So what I'm hearing then is there are multiple use cases for metal, and you're going to have like medical management folks that make use of the data for insight into chronic disease management. You're going to have finance people. I don't know if that means at the TPA level or at the broker level, that's looking at the data that's coming in saying, hey, this is a red flag. This procedure came in priced at 10x Medicare. That's something that we need to put eyes on. So I see, what I'm hearing at least is there are different use cases, and really, is it going to be up to who is the hub? Is it the TPA? Is it the broker advisor consultant? Ideally, who is managing the information that's coming in?
Yeah, great question. So I would say that the use cases are varied in terms of who wants to use it, but it's still, there's two real parts of where you get value out of the data. One is transactional. So that's all of the data as it comes in, making decisions in real time. And when I say in real time, it's only in real time because claims data is always delayed, as it comes from providers, often weeks late. So there's those type of people which are like plan solutions that are trying to do certain types of things. So you mentioned medical management. They're a perfect example of this. We have some medical management people that are interested in using and actually using metal for their medical management services. So for example, they want pre-auth information. So that's a great example of something where if you get pre-auth information and load that into metal, then what you can then do is you can say, okay, I have real time as we can get, ability to see pre-authorization requests as they come in. Now I can get on the phone if I'm medical management and say, hey, I see that you've got this procedure coming up. Can we help you find the best care for that? So that's a great example of like transactional flow, like as data comes in. But then there's also the reporting flow, which is really more like what the broker community is primarily going to be doing. There's a lot of brokers that are very hands-on, consultant brokers that are very hands-on dealing with transactional things, but many are focused on analytics and saying, hey, how can I make better choices? And they put together the right program. I would say that's the primary focus for the broker consultant community, is how do I put together the right program? Oftentimes they'll then hire people to do the transactional stuff. So those are the two use cases we're dealing a lot with today, is the transactional, which are plan solutions that are actually administering health plans. And then we've also got the analytical side, which is primarily people that are analyzing it, trying to make decisions and trying to put together the right plan. Like that'd be where your broker consultant kind of sits. And so we straddle both sides very easily.
Yeah, no, and I could see a ton of value here because, so folks, if you think about your health plan, most boots on the ground employees are not aware of what would I call it, the infrastructure, the skeleton, the foundation, the beams, right? You don't walk into a home and see what's behind the walls, right? That's not all you want to do is you want to go to the doctor, you want to give them a card and have them treat you. Hopefully you're guided to the highest quality care at the best price. You know what your cost is going to be, and then you're on your way. So that's like the old, right? It reminds me of the honeymooners. I'm dating myself big time. And I didn't see the original honeymooners. I caught the reruns, folks. Let's be real. But the chef of the future, right? This is how they used to do things the old-fashioned way. And it was work and work and work and sweat. And now I have, what the hell was it called? Do you remember? Kitchen handy helper. Anyway, Norton had a device that made the job way easier. And so I think and I'm the chef of the future. So the idea of the future of healthcare is to have a plan that has employees who are more engaged with the process, and not saying more difficult, but more engaged. And what I mean by that is the plans that me and my colleagues are building, custom plans, are incentivizing employees and driving them to the highest quality care at the lowest cost. And when employees accept that steerage, and there's data behind it, and that's really where Rob comes in, when you accept that steerage and you say, I don't just want to go to a doctor based on a directory as it's done today, I want to be guided to the highest quality curated care that's appropriate for me. And when I go there, my plan is going to reward me by waiving all of my out-of-pocket costs. So it's not going to cost me anything. That is the future, I believe, of healthcare. And I think it starts with a DPC model or a value-based care model where you actually have a relationship with your physician who knows you, who cares about you, who's not saddled with 2,000 patients, but a fraction of that, a quarter of that, 500 patients. You're not waiting around their office hours when you get there, and it doesn't take you 6 months to make an appointment. The whole model is flipped upside down. You're there, and they're seeing you in a day, if not a matter of days. And when you get there, instead of 2 hours in the waiting room, they're actually spending a good 30, 40 minutes with you instead of just, rushing you through the process so they could get to the paperwork that they need to fill out before they see the next patient. And that's what we're referring to. But where I see your tech coming in strong is in helping identify where the offenders are. Because let's face it, Rob, no one has a magic wand. I can't stop cancer from happening. I can't necessarily prevent I was going to say diabetes, but type 2 diabetes is quite preventable. But if you can see the indicators and, okay, this patient, based on their treatment, based on their interactions and the bill charges that are coming in, we see a pretty big segment of our population that would benefit from a service like DiaThrive that is going to greatly reduce the costs for diabetes patients, diabetics, and that is going to have a huge impact on the claims costs specific to that disease. That insight and that data is invaluable in helping identify that. And so before you even install a program like that, you would have the insight or the foresight to basically say, we need to address this. And in addressing this, we're going to accomplish two things. We're going to dramatically lower our costs for this condition, and we're going to improve the lives of our employees and their loved ones who are on our plan in managing the care of that condition. So that's a huge win-win. What I'm hearing, though, is you do have clients, but I'm also hearing that this is an active work in process. This isn't something where you blink your eyes like I Dream of Jeannie and boom, there it is. It's done. Our work is done. I'll see you at the jacuzzi. That's not the deal at all. It's something that has got layers. And what is your vision, I guess, is where I'm going. Where do you want to take this thing?
Yeah. So I guess two comments. One is you mentioned the analytics and different layers. And speaking about DPC, we had two DPC providers and solutions that came to us at Rosetta Fest and said, hey, we want to be able to identify reporting to be able to say, you know what, we're going to introduce DPC to our plan next year. And we want to then be able to identify a cohort of people and say, hey, these people switched over. This is what we were spending in both primary care and all other types of care beforehand. Here's what we're spending afterwards. And we want to be able to identify this in a standardized way that everybody can use. So anybody that's doing DPC savings analysis, for example, can use the same cohort identification method and the same way of being able to identify savings. Because ultimately, that's one of the challenges that plan solutions often have is they go live and they're like, how do I identify that I saved somebody money? And if the only way you can do that is by saying, I can compare your primary care costs to your primary care costs, that's not the benefit of DPC, because the belief is that with DPC, you can lower all the other costs as well. You can lower outpatient visits, you can lower drug costs, you can lower inpatient costs, all those things. And so you need a much more sophisticated model to be able to do that, those sorts of analyses. Metal can help with that. So that's a great example. And when you mention where do we want to see this go, I mean, what we want to see happen with Metal is a community of people come in and join and participate. And what do I mean by that? I don't know everything. You know, we're working very closely with Health Rosetta on this. Between everybody we've got in the Health Rosetta company, between all the people in my company, we don't know all of that there is to know. Frankly, we don't know very much if you think about the entire healthcare ecosystem, about how to solve these problems. So in order to solve these problems, we need a community of people that come together to solve these problems together. You know, I talked about DPC analysis and cohort identification. I mean, I get that in concept 100%. Would I know how to identify that in a way that could be standardized across every single DPC provider in the country? Absolutely not. And frankly, even the two people that I talked to about this at Rosetta Fest, they don't know either. Because in order to be able to generate a solution that meets everybody's needs, you need to gather everybody together, or at least enough people together that you can start throwing rocks at the things that people have problems with. Because anytime we identify a fix to something, there's going to be somebody seeing it from another perspective, and they're going to say, I don't like that. So that's what we're building right now in the Metal community. Metal is part of the greater Nautilus initiative at Health Rosetta. And Metal, you can find out more about Metal at metal.dev. So it's for developers right now. Eventually, we're also going to have metal.health. But right now, metal.dev is where you can find out a little bit more about what we're doing. It's part of Nautilus. And this is part the nautilushealth.org is where that's at.
And Metal would be METL.
Yes, thank
right?
you. Thank you.
Okay. Yeah.
Thank you. And so the vision is let's gather these people that are interested in this. Let's gather people that are interested in figuring out analysis solutions. Let's gather people that are interested in finding out transactional workflow problems and finding fixes to those. All these sorts of people have different skills and knowledge that we don't have today. And we need those people to be a part of this. One of the people that I ran into at Rosetta Fest was a guy that happens to be an expert at EHRs. And I was like, this is amazing. I want to talk to you because I have questions about EHRs. And it's every time we get additional people.
What's an EHR?
EHR, electronic health record. So this is what our really large health systems use to be able to keep track of all of what happens in the hospitals. And the example that I gave in this conversation was like, hey, if I need to do line item audits on a claim because maybe the claim was really expensive and I want to see what happened to it, I would love to be able to just request the EHR data instead of having to get faxes, because that's what providers like to do today is they like to fax me. And they'll say, oh, by the way, it's $5 a page and it's 2,000 pages. Do you really want to spend $10,000 to get all these pages? And what they're banking on is that you say, oh, well, I only want these 200 pages. And they're like, oh, phew, they didn't ask for the ones that actually were the worst ones. But anyway, so there's all kinds of little things that each
Isn't
one
it
of
ridiculous that we're using faxes in 2024?
Yes,
and there is a reason for it, isn't there, Rob?
there is absolutely. People
The answer is money. What's the
they
question?
want to hide all of their double dealing and everything else
Holy.
as much as they can. Let's face it, there is a lot of intellectual property people have developed over the years. And if we're good businessmen, we say we want to save and protect our intellectual property. Every day when I'm on LinkedIn, I read article after article after article about ways to protect your intellectual property and ways to be able to grow your market share and all these things. And if you ask me if we want to fix healthcare, we need to stop thinking so much about how to make more profit and how to make people healthier. Well, a lot of times those are at odds with each other. And so Metal wants to reduce and remove as many of those things. So we're looking for people that are fed up with today's system. People that are, we've got a good friend that's a former data analyst, former deputy director at Optum Labs that's helping us out with some analysis. We've got really, really smart people. And in order to be able to accomplish all of what needs to be done, we need a lot more really, really smart people, because it's this coalescing of all these ideas and knowledge that helps us get it done. And we're doing it in an open source fashion. So we're not trying to make a bunch of money off of this. All we're trying to do is bring in enough support from the community to be able to support the development and technology efforts that we're making. And nobody's getting rich off of this. We're just doing it because we think that the world needs to be done. Healthcare needs to be done differently in this country. And
so if you go out to your website, I'm pretty sure you have 3 tiers to this offering right now. Is it $1, $2, or $3?
Yeah, so that's for My Price Health. So that's my company. That's separate from Metal, but we do bundle in the pricing services. So yeah, that's a great question. My Price Health. The way that I make a living is I price claims to contract and to Medicare. And so we'll do this. Our goal is to make it like water. That's what Sean Shanson used to say to me when I started this. He's like, repricing claims ought to be like water. It ought to be like readily available and really inexpensive. And so that's our goal. We're the only repricing vendor that I know of that has their prices on their website, because we're not about trying to raise prices. We're not about like, call us to tell, so we can walk you through this gigantic long integration process and throw in more and more and more dollars on top of this. Our goal is to try to lower the costs of that. And so that's what I do to be able to make a living. The reason why Metal was created is because I needed to build a data analytics platform and a transactional analytics platform to be able to reprice claims. And Sean at Health Rosetta was like, I need an analytics platform, a data analytics platform. And we're like, well, this is stupid. Why don't we just join our resources instead of you building one and I building one, which is what everybody else is doing in healthcare? Why don't we build it together? And so that's what we're hoping happens with the rest of the industry, is that people are like, hey, you know what? I believe in this vision. Let's join together. Let's add technology to this. Let's add our ideas. Let's add our reports. Let's add our cohort analysis. Let's add all these capabilities. And we believe that we can do this in a way that is lower cost and more sustainable than any other solution that's out there today.
Awesome. Yeah, it's really cool stuff. It's interesting to me that you're able to join forces and work on this together because, well, one of the things you said is the data is not as vast as everyone thinks, right? So that's one piece of it. But also, though, there are a lot of moving parts. And to bring it all together, it's probably beneficial to have 2 teams, 2 organizations working together on their specialties and then bringing it together. It sounds to me like a lot more efficient way to get the job done. But man, there's such a need for this right now. Just think about it, folks. If you had insight into the data that big insurance and big pharma don't want you to have access to, might that change things? And to Rob's point, if we can find waste and bloat in the system, and I'm here to tell you firsthand, I've saved clients with multi-million-dollar spends 50% on their spend. And now if you could take those dollars and with the help of Rob and his team, with the help of a Nautilus through Health Rosetta, if you can make it, and that if that information was transparent and the access to it wasn't like pulling teeth, how much better off would we be? Can these organizations, can they take that money and drop it straight to their bottom line for their greedy purposes? Sure, they can. But I think the big picture is if they can at least take a portion of that savings and reinvest it back into their people so that they could pay them a decent wage, have them be able to take time off with their families. We're talking about improving the quality of lives of the heart and soul of America, as far as I'm concerned. Yeah. And so it's a huge and worthy cause. And I don't know why you signed up for it. It sounds like a lot of it sounds like a lot of hard work to me. But thank you for doing this. And is there an end in sight? Do you see, I know it's a work in progress and I know it's a coordination of teams, but do you have a goal for when a finished product might be ready for prime time?
Yeah, and I'll share two glimmers of hope. So one glimmer of hope is, so Patient Rights Advocate has been doing tremendous amount of work trying to get new legislation in place that will require healthcare plans to have access to their data. So we were involved. So I personally wrote the language that went into the Braun-Sanders bill for access to data. So what that was is you as a plan get full access to all of your claims data, unredacted from the provider, and you get access to all of the post-adjudicated claims data, all the stuff that's going into metal. So the bill said all of this stuff is required. So if that, let's just pretend, let's hope that bill goes through. What happens at that point is every employer in this entire country suddenly has access to data that today they don't know anything about or anything about what to do with it.
And it's regardless of how many employees are on plan, whether it's a small plan, large plan, self-funded, fully insured.
It excludes fully insured, but anybody self-funded would have access because this is part of ERISA. And so basically at that point, any employer in the entire country suddenly gets access to all this data. And we believe Metal is the platform that would be the ideal place for all that data to land once this data goes live. Now, imagine you're that employer and that data suddenly lands at your footsteps and you launch an instance of Metal and you're like, oh, look, here's what my prices are. Here's how much I was paying. Here's a graph that shows me where I'm spending my most money. And here's a button I can click on that says, connect me with a consultant that can help me understand this. This is like the whole new world. Like I'm going to start singing that Aladdin song. It's like this whole new world of I now have access to information that nobody has ever given me before. And so you're in a situation where you're like, oh, this isn't a magical thing. It's something that I can actually do something with. Purchasing agents all over the country would be all over that kind of data because they'd be like, look, I have purchasing power. And that's the kind of information that we believe is possible. So that's glimmer of hope number one, which is we hope to have that legislation go in. And glimmer of hope number two is there are lots and lots of TPAs we've already got signed up that are very much aligned. So even if you don't have one of the TPAs that won't give you your data today, there's lots of TPAs that will. So we can switch to the TPAs that will. You get access to your data and you can immediately start making these decisions. Yeah. So it's possible today. We don't have to wait for the tomorrow that is nebulous. Maybe it won't come. Maybe that bill will never pass. Let's hope that it does. That's my goal. I would love to see bills like that pass so that everybody can start making these kinds of decisions. But if it doesn't, there are plenty of great TPAs that will. And what happens if the market moves in that direction is eventually the other players that are not playing fair, that are taking $1 million claim and turning it into an $11 million claim because they just want to pad their pockets, those companies will get sued, those companies will see people leaving them, and we will see a sea change in the industry of people going to transparency, because that's where the future is.
Yeah, it's a beautiful vision. And folks, many of you probably, it might be a little abstract when Rob is talking about TPAs, third-party administrators. They are handling all of the nuts and bolts of the transactions within your health plan. And for those that are in love with that Cigna logo or that United logo or that Blue Cross Blue Shield logo, when they are also the TPA, which is the case quite often, that's where you're really having difficulty getting transparency and getting your hands on the data. And on the other hand, if you have an independent TPA that is transparent, and there are a good number of them out there that are aligned with an advisor that is on your side, working with the organization that employs you and really with your best interest at heart. And how do you know that? Like, so an advisor, all of these are for-profit entities, right? So everybody is out there. No one is working for free. But at the end of the day, I think what you want is alignment and transparency. So if your broker is playing by the rules of big pharma and big insurance, they're getting all sorts of compensation that is generally undisclosed. It's not being reported on a 5500. It's the old boys club, right? You don't want that. What you want is a broker and an advisor that is showing you the good, the bad, and the ugly. Here is all of the compensation that we collect. And further, I want to be rewarded when we reduce your costs. So I'm not accepting a bonus from a United or a Cigna or a Blue Cross, and I'll put that in writing and we'll both sign it. But when we do what you want us to do, which is elevate the quality of care and reduce costs, then will you pay me a bonus based on plan performance? That way you're aligned. And I'm giving you one example of many, many different ways that these arrangements can be made. I think the key is you want everything to be transparent and crystal clear. I know that's what I want as a consumer. I don't begrudge doing business or hiring a contractor and knowing that the contractor is going to make a profit and that's how he pays his bills, his workers, puts food on his table. I just want to know that I'm not paying $3,000 for an install that I should be paying $300 for. And we don't know that in healthcare. And so the work that you're doing, Rob, is awesome. And I'm a little bit of a pessimist. I'm hugely optimistic in just about any aspect of my life. But when it comes to healthcare, being against a $4.5 trillion going on $5 trillion buzzsaw, and you talk about getting bills passed and change that's going to benefit the little guy, I got to tell you, I'm exhausted just thinking about it. But I hope you get there. And you know what? I do think that we're at a tipping point. I think that we're at a place now where all the juice is squeezed out of the lemon. There's really nowhere to go from here. And I think people are fed up.
Absolutely. Absolutely. Yeah. The time is right for change. And you can see that in all the legal rumblings that are going on. There's tons of lawsuits right now where people are fighting back. It's the right time. Employers are fighting back. Employees are fighting back.
Yeah.
So employers are making lawsuits against the networks because they're getting screwed. Employees are saying, hey, if you're not going to manage my health plan effectively, then I'm going to sue you. So we don't like to live the world in lawsuits, but the reality is lawsuits are what turned the investment market,
Sure.
501ks, into a well-oiled machine. And we believe that, say again?
401ks.
Yeah, 401ks, that'd be your employee retirement plan. So the 401ks are a part of the same ERISA law as what health plans are. And so what's interesting is right now we're seeing a ton of legal fights in the same sort of vein as what we saw decades ago with the 401k space, where people are saying, you need to disclose your compensation.
Sure.
You need to disclose the methodologies. You need to that's all this really is.
Yep.
Healthcare is not magical. It's just I got a bill from somebody and I paid it at a certain amount. There's no reason why that should be hidden. And the only reason why they're hiding it today is because they're trying to make a big, huge profit off of it. And we need to make that so that is fully disclosed and fair.
Hear, hear. Listen, I'm encouraged by what's going on in the industry. I'm hearing a lot of rumblings of more and more lawsuits, and I don't think lawsuits are a good thing for anybody, but it may be what's needed to light the fire, if you will. But the recent Senate hearing and folks in our circles, Dr. McCary and Peterson, the Petersons, and so many other great minds coming together to testify before a Senate committee on what's going on in healthcare. I think that stuff is very encouraging, because if our politicians really take a minute and they look at what's going on, they pull the covers back, they're not going to have any choice but to get behind this movement and enact change. It's costing us dearly, and it's more than money. It really, the ultimate price is being paid in human lives. And it might sound crazy to say that in the same breath as we're talking about a data company, but those two things go hand in hand. With transparency comes not only savings, but it also comes along with just huge benefits for people, for our friends, for our neighbors, for our family members. So Rob, thank you for joining us today. Thank you for the mission that you're on. And just one last time, how do folks find you?
Yeah, so if they're interested in pricing services, they can go to myprice.health. That's our website. And they can also go to metl.dev to learn more about metal. And if you're interested in the larger ecosystem around, that's nautilushealth.org.
Awesome. Well done, my friend. Thank you so much for joining. Hopefully you could come back again one day and give us an update on how things are going. And if the gods smile on us, you'll come back to us with some great stories about growth and prosperity. And we wish you all the best.
Yep. Well, thank you so much. Appreciate it.
All right, folks. Until next time. Peace.
So that's it for today's episode of Broken Healthcare. Head on over to iTunes or wherever you listen and subscribe to the show. And join us on the next episode.